Hello and welcome to the AMA Update video and podcast. Today we're talking about one physician's unexpected journey from working on the front lines to becoming a physician leader and an expert in basket efficiency. Our guest today is Dr. Reggie Lyle, Medical Director of Informatics at Baptist Health in Corydon, Indiana. I'm Todd Unger, AMA's Chief Experience Officer in Chicago. Dr. Lyle, it's a pleasure to have you with us today.
Thank you, Todd. I'm glad to be here. Thanks for the opportunity.
Well, before your current position, you worked as a family physician at Baptist Health all the way up through 2022, and then something happened that changed everything. Why don't we just start there? What was it?
Okay. Well, going back to 2021, February of 2021, I had been visiting our daughter and grandson for his first birthday in the D.C. area. And we had traveled, and Super Bowl Sunday, actually. And during the night, I woke up with a seizure and was taken to a local hospital, a community hospital, and had a seizure workup that was normal. And while I was undergoing a workup in the ICU, I had some prolonged pauses and some pretty profound bradycardia. I was transferred to a tertiary care center and had another episode and underwent an emergency pacemaker placement. They originally thought it was sudden cardiac death, that I was a survivor of sudden cardiac death. It turns out it may have been, or it may have been a seizure and a prolonged post-ictal period. They're still not sure. And so my wife and I stepped back and decided we wanted to look at other options. I was 62 at the time, coming up on 62. We decided to leave clinical medicine and to spend more time with grandkids.
Well, let me just ask, when you started talking about the timing, I thought this would be a COVID-related story, but obviously really serious. And I'm sure that experience would make anyone in your position, really rethink how things were, maybe consider retiring, change of pace. But you got offered a new opportunity that you couldn't pass up. Tell us more about that.
Right. Well, we looked at my father died at 57 when his grandchildren were 3 and 1. Never got to spend any time with them. So we prayerfully considered what we wanted to do and decided that I would start cutting back on what I was doing. One of the things I was doing, I was a medical director of quality for our medical group that now has 1,800 providers in it. And so I cut back on that and started transitioning out of it. But before I could transition out of it, we decided that we would just leave clinical practice altogether. In the 6-month transition period, then after that, when we were leaving clinical practice, Dr. Isaac Myers, who's our Baptist Health Chief Integration Officer and President of the medical group, and Dr. Brett Oliver, who is the Chief Medical Information Officer, got together and they offered me a position that utilized my geek skills, my tech skills, my history of work with quality, and my clinical experience to combine for a unique role that could be done mostly virtually. And so it allowed me time to travel and spend time with grandkids, work early in the morning, and still get the work done and be able to spend time with the grandkids. So that was an opportunity that they gave me back in 2022.
Now, this is interesting because you're the second physician I've talked to in the past week that is now in the informatics world. Just for folks out there, basic kind of, what does that mean that your day looks like? What kind of things are you doing?
Yeah, right now, my main focus, Dr. Oliver asked me to focus on in-basket and the burden that it was already providing before COVID, the in-basket. I don't know if it's generational or what, but with my chart and other in-basket opportunities, patients feel they have 24/7 access to their primary care, especially. And so they're messaging 3, 4, 5 times a day, wanting symptoms taken care of, things that require medical decision-making, and they just disrupt workflow. So you're trying to see patients in an office and you're getting most of our providers are getting at least 100 messages per day.
Mm.
And so you add that on top, it's just that it's an overwhelming burden for primary care providers. And it's something I'm passionate about and working with it. And so I began focusing on everything Epic and InBasket starting back in 2022. And so I followed different organizations. I've been working with a really good team trying to put together some efficiency optimization and looking at it more from an operational standpoint now than truly a tech standpoint. We've just about reached all we can do from a tech standpoint. I mean, AI is going to change it a little bit, but still, we're going to require some medical decision making and some workflow and workforce issues that have to be addressed to optimize InBasket and help improve work-life balance for our providers.
That makes a lot of sense. I think just with any new technology, I don't think the expectations are quite set there, certainly with patients in terms of response time and not really realizing just what that flow looks like on the other end of the physician. In your work that you've been doing so far, do you have any insights or success stories that you can share with us based on what you've seen?
Yeah, so one of the biggest insights I've had is that this is not unique to any single organization. This is an issue that has been created by several different factors. And probably one of the big ones is that our decision that's been kind of pushed on us by payers over the past several years that we are now data directed, not just using data to support what we're doing, but we are being directed by data. You know, Goodhart's law is an economic law from Charles Goodhart back in the 70s, who talked about, I'm paraphrasing, but he said that anytime you take a metric and tie a reward to it, immediately becomes a bad metric. And that's what's happened is we created a set of metrics and then tied reward. Our payers have tied rewards to those metrics. And so now we chase the metrics. And so the ultimate goal of a healthcare system, in my opinion, is that we optimize the provider-patient encounter and that experience to promote the healthcare of that patient. Well, what we've done is we've taken data and metrics and overwhelmed the providers to where they can't do that. And so they end up chasing the metric and chasing documentation and can't really take care of the patients. And the patients are the ones that are suffering. And now we're hearing terms like moral injury and burnout and things like that. And it's all a direct result of the immediate access and texting and then primary care access plays a part of that. If you've got a patient, it's really easy for me to sit in an office and say, that's something you need to come in and see me for. But if my next appointment is 6 weeks out, that doesn't do them any good. So how do we address that? So those are some of the things we've been working on. How do we fix those issues?
Yeah, these kinds of administrative burdens that you're talking about directly result in physician burnout. We know that a lot of physicians are spending significant amounts of time at home. They call it pajama time, doing things like reviewing notes and working in the EHR and probably responding to email messages like this. The day just kind of continues. When you have analyzed this and you're looking for solutions, is there anything that you've come up with that is helping?
Well, there are several things we're working on, and we are in touch with organizations across the country, mostly Epic shops, because that's what we use. And so we work with our Epic teams, but we're also working on the thing that I'm most excited about. We're starting to pilot this soon is a program we're calling VASER, or DASER, which is a virtual acute and subacute encounter resource, which allows at the provider level the decision to be made about whether or not InBasket messages are handled by a virtual team or they handle them themselves. In an ideal world, the primary care provider knows the patient the best, should take care of those messages. But sometimes, your son has a basketball practice at 3:00 you need to get away from, or you are up on call all night, or something comes up that you just can't handle any more messages today. Well, we're looking at putting together a safety net where you can just on a dime turn and say, hey, can't see anybody else today. I can't handle any more messages. And it gets sent to a team, a virtual team that has options for medical decision making, has a provider embedded. It has more advanced staff. Medical assistants are not part of that. It's LPNs, RNs. We're also looking at moving in case managers for social issues, as well as pharmacy for taking care of INRs, medication refills, things like that that can be handled at a remote location. So our organization has 6 different markets. We have 1,800 providers, 450 something that are primary care providers. And so we have different markets, and they have different needs. And some providers want to see every message that comes to their in basket. Some don't want to see any. So we want to, part of the challenge was to make it where the provider level could be where the decision was made. And if they chose not to take care of the message, one of their advanced practice clinicians or another provider in the department or the group could see the patient that day. So it could be shuffled there, and if not, then to the virtual major team. That's what we're looking at. We're starting to pilot that. Hopefully by the first of the year, we're getting on some of that set up. The other thing that is important is we live in a world where budgets are important, and especially in the ambulatory world. We talk. I talk about the 3-headed beast of healthcare these days, and that 3-headed beast is that even though we talk about quality, we still live in a pay productivity or work RVU based world. So the more patients you see, the more money you make. So we've got that, but we also have a portion of our income that is related to the clinical side, and then we had thrust upon us the patient experience part, which many of us years ago knew that was going to be very difficult to navigate. And so when you put those 3 things together, you've got to keep the patient happy, you've got to hit quality metrics, and you've also got to see more patients. What do you do? And that's where we have to come up with some innovative solutions to help our providers so they don't get burned out, and so we can attract more primary care providers. We have a large portion now that are nurse practitioners are moving into primary care, which is is going to happen. They feel a need, and they're very good. The ones we have that I work with are excellent at providing care, but even they are burnt out. And then, just what do you do? And so we're trying to figure out ways to limit that burnout from that, and also try to teach or help the organization understand that we can't set this team up and make us money. It's not going to make us money. It's going to prevent us from losing providers. One of our regions recently lost 3 primary care providers, and when they did an offboarding survey, the number one reason was the in-basket. So, it's real, and there's a lot of data out there now about that. But there again, I want to use data to support what we're doing, not to drive what we're doing.
Absolutely. And just for folks out there too, there is a lot of information and resources related to in-basket management and AMA Steps Forward section on the website. I encourage you all to check that out. Dr. Lytle, just in closing, any advice? You mentioned that you're working with a lot of folks across many different systems. This is not a system-specific problem at all. And in fact, we hear this from lots of different physicians out there. Any final advice to folks who are dealing with this situation?
I think from a system perspective, I think listen to your clinicians that have the clinical experience and have worked. It's easy for us to rely on MBAs and people with healthcare administration degrees that don't have much clinical experience. That is important. But again, listen to your providers that have clinical experience and what they're living through, and let them help you work through solutions, because there are solutions out there. And to also try to stay out of silos, find physicians that can be champions that can cross silos in different areas within your organization to give a better perspective on, especially those that have owned their own practices in the past. Although I think we're becoming dinosaurs. Those of us who have owned their own practices and had to deal with all of this on their own without organizational help. Well, we're becoming dinosaurs. But just listening to them and listening to them when they ask for resources and not make it all about, is this project going to make us money?
Well, thank you so much, Dr. Lyle, for that perspective. Really, really important. We'll be keeping an eye on your work, and we're going to look forward to hearing more about it as it progresses. Reducing physician burnout and improving practice satisfaction are top priorities for the AMA. We encourage you to support that work by becoming an AMA member at ama-assn.org/join. That wraps up today's episode, and we'll be back soon with another AMA update. Be sure to subscribe for new episodes and find all our videos and podcasts at ama-assn.org/podcasts. Thanks for joining us. Please take care.